Welcome to Joint Effort with Des Moines Orthopaedic Surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Welcome to another episode of Joint Effort. Tonight we have Patricia Kallemeier, one of my esteemed hand surgeons, partners at DMOS. Welcome.
Thanks, Jason.
Thanks for coming on, Trish. We very much appreciate you having you. And you're the first hand surgeon I've gotten to talk to, so you'll see how rusty my knowledge is of that
Awesome.
area. Okay. Just a little bit of background. We want to get to know you a little bit for
Sure.
our audience. So you went to undergraduate,
University of Iowa.
University of Iowa, and then medical school.
University of Iowa.
It's very unique.
Yes.
You just kind of thought, okay, I like Iowa City.
Yeah, it's okay. I'll stay here.
Keep it rolling.
I don't have to move. This is good.
And is it true that initially you thought you wanted to be a general surgeon?
I did, and I matched into a general surgery program.
Okay.
At Hennepin in Minneapolis.
Which is the county
hospital. Yeah, really
Very
crazy, busy trauma center, and realized quickly that I liked orthopedics.
So were you in your intern year when you pulled the chute?
I did. So I had to rematch,
Okay.
actually, which not many people do.
No.
And so I sat out my second intern year. I sat out and did research for a year,
Okay.
which was
So
kind of nice because, you can actually see the city.
Yeah.
And
They didn't make you repeat doing an intern
they
year
didn't.
again.
I had some sweet talking and got through it.
Was it
great.
just a really aggressive morbidity conference for general surgery one day where you're like, I can't do this? Or what?
No, actually I did my second month my second rotation was ortho, and it was a trauma service,
Okay.
which I hadn't been really exposed to in medical school. So it was awesome. And I worked with a hand surgeon there. It's a lot of it's who you get exposed to and
Sure.
and your mentors, and it was fantastic.
Okay.
So was able to rematch and
And
thankfully stay in
they kept
Minneapolis.
you there?
Yeah, they did. Yep.
So they liked you enough?
Yeah, it was
Did
good.
that mentor have some role in that?
I think
I'm
he
guessing?
helped out. Yeah, he was fantastic.
Well, I think so. You basically made a change from general surgery, pretty intense. Ortho can be pretty intense too.
Yeah, in
Did you
different
know-
ways, but yeah.
Were you kind of like, I'm doing ortho to do hand, or were you like, I just kind of like ortho and I'll figure out from there?
I went into it a little bit more open-minded. I actually really like spine, which is kind of a opposite ends of the spectrum, but found that I really enjoyed everything about hand, and there were so many different opportunities. Hand you can be a shoulder and elbow surgeon and a hand surgeon. I thought maybe I'd do something like that. And once you get into your practice, it changes. And
Just
I've really
kind of leads you where you
it
can
does.
kind of figure out what you like and mold it from there.
Exactly.
Okay.
Exactly.
So you get through Minnesota, and then, so how many residents a year at Minnesota when you were there?
How many residents per year?
Yeah, per year.
There were 8 in my year.
How many females of the 40 in
One.
the program?
Oh,
You?
no, I'm sorry. My year one, there was one ahead of me, two ahead of me, and then the class behind me actually was 2 women. When I left there, it was 50-50.
I was going to say, I feel like there's been a movement towards more women in orthopedics
Yeah.
over the last 10 or 15 years.
Agreed,
Do you
which
feel
is
like
great.
you blazed the trail for these
I
ladies?
don't know if I can take that credit, but it's been a great specialty, and I think it's most important to get that exposure early. I worked with a plastic surgeon who was a hand surgeon, and it was a female at the University of Iowa, and kind of started my interest in hand at that point. And I had great mentors at Minnesota. There was, I want to say, 5 women in the department.
That's great.
So
Yeah, so
unusual,
you had role models.
compared to other programs.
So you could kind
certainly.
of ask them, how's this going to go?
Sure,
and is
sure.
your life normal?
How do you have kids, and when do
Yeah.
you have kids, and all that stuff.
And many
So,
may not know, but you have 2 children yourself.
I do. Yep, 2 girls. Yep,
And they're getting big, and they're
they're growing up.
pretty good divers, aren't they? Isn't
Yeah.
that what
Yep. Yeah, they're really into gymnastics, diving.
I don't know how you find diving as a hobby in Iowa, but you guys somehow found that.
Definitely a niche that not everybody finds. But
And
yeah, it's been
you
great.
didn't dive?
No, I played basketball, volleyball.
Okay.
I ran a little track.
Is
but
it fun
nothing.
watching? Can you tell when she hits the water wrong? and you're
I'm
like-
learning a lot. Yeah.
It's no splash, right? You try to.
No splash. Yeah. Yeah.
That's all I
yeah.
know from the Olympics.
Try not to hit the board and no splash.
Twist as many times as you want,
Yeah.
but you don't want to create a splash. That's all I kind of
Yeah,
remember.
we laugh about the triple Lindy, and
Yeah.
and it's not a real dive, but it's fun.
That's pretty funny.
Yeah.
So from Minnesota, then you thought, okay, hand is an interest of mine.
Yes.
And then you did an extra year so you could specialize in that.
Correct. Yeah.
What's the value in your mind of doing? Everyone wonders, if you do 5 years, why can't you, and some people can do everything, right? But for you, what's the added value in that year towards your practice still today?
I was at WashU in St. Louis with my fellowship, and the curriculum there was fantastic. Every week we did a different dissection of the hand. We had cadaveric dissections, and we were prosecting. We had a resident below us that was doing the physical dissection. And you just learn the anatomy so much better. You get exposed to so many different things. One of my mentors there did a lot of free flaps and.
When you say free flap, describe what that means.
When you have a defect in, say, an area, typically
you lose skin or
muscle. You bring in skin or muscle from another area that you have to plug into the blood supply and give it enough nutrition so that it can survive.
That's a pretty tenuous time,
right.
The first week or so. You check
you're watching it,
or what's it look like?
You're checking them twice a day, and we did a lot of replants at WashU. You just get such a better in-depth training, and you have an opportunity to do some research. Did a research paper during my residency, then also during fellowship.
So you come out feeling like
you feel so much more confident.
Yeah, you're not mastered of anything, but you have an idea of where you need to get to in any topic around the hand.
Well, you know the anatomy so much better, and you can just you can do almost anything if you know the anatomy.
And then did you come out of there with some good resources you could rely upon if you needed to in your first year or two?
Sure.
I mean, everyone needs
hey, what do you do?
I guess I didn't see this in the 6 years,
right. Right.
It's amazing, even I don't know, are you 12 years in now to practice?
13.
13.
Yeah.
Isn't it amazing how you can still see things that you have
still
not
see
seen
things,
yet?
At least every 6 months.
Especially in the hand,
before.
you think, okay, but it's crazy.
It is humbling. You think you're doing great, and then I haven't seen that. So yeah. But you find ways to. It also teaches you ways to figure out the answer to questions and how to research things. It gives you a huge pool of people as a resource as well.
Yep.
So
one of the stereotypes, probably a good stereotype of hand surgeons, is how meticulous you guys are, right? Because attention to detail, I mean, it's a pretty small area you're working in, but there's so many things that can go wrong or can be treated. And so I think we kind of have an understanding that you're the right person for that job because of you're going to general surgery. Right. You're pretty, you're intensely focused about certain topics. So that's set you up for success in your career so far, at least from what I've seen. All your patients love you, and you have a great reputation. What we want to talk about today is the thumb.
Sure.
And what I think would be interesting to talk about is specifically arthritis at the base of the thumb.
Sure.
Commonly called the CMC joint. Is that correct?
It's interesting. It's got a lot of names.
Okay.
I did a research paper, a review paper when I was a resident on
really?
Thumb arthritis. Yeah, I don't think I told you that.
No.
And when I did the literature search, you have to type in all these different names because it has so many names. The basilar joint, some people call it the basilar joint, the trapeziometacarpal joint, or the TCM joint, or TMC joint. The first thumb CMC joint. So it's got a million names. I call it the thumb CMC joint.
Thumb CMC joint.
Yeah.
Okay. So give me an understanding. Obviously the thumb is probably the most important finger for a lot of reasons. Or maybe I'm making that up, but it sure seems that way, right?
It is. Yep.
And so what does this joint allow the thumb to do?
So one interesting thing, if you look at your own hand, the thumb is in a different plane. All the fingers are in the same plane. They bend in the same way. The thumb is out of plane, so it's off by about 45 degrees, but it has much more mobility, and that's one of the reasons people get arthritis at the base of their thumb. It allows you to bring your thumb out of the plane of the hand so that you can pinch to it.
So you're gripping things a lot with your thumb.
You are, but it's more of a post, really. Its job is to be stable so you can pinch things.
Got it. So you're putting things up against the thumb.
Correct.
To hold it secure. Is some of the increased force, or is it maybe a nutritional thing where you use the thumb so much more than any other finger that leads to arthritis there?
That's interesting because there's a lot of theories on that. there's some there's a higher percentage of women who get arthritis of the thumb than men, so they think there might be some hormone receptors at the base there.
Okay.
Sometimes it's a post-traumatic problem where somebody gets an injury and then they get arthritis afterwards. There's some theories about obesity and whether or not some of the hormones in patients who have obesity, if that leads to higher risk of arthritis there. There's never been anything that shows it's a work, that certain work things can cause it. It's typically something that happens over time. If you look at, there was a study back when, this has been 20 years ago now, but a study out of Scandinavia, and they found that a third of women that they took x-rays of had arthritis who were postmenopausal.
Not necessarily symptomatic, but just...
No, and only a third of those women had arthritis pain. Okay. So you can have arthritis and still not even have pain from it. It's pretty interesting. People come in all the time who break their wrist or whatever, and we get an x-ray, and if I see arthritis, I ask them if it hurts, and it's amazing how many patients don't have pain from it.
They just accommodate.
Or it gets stiff and it becomes less painful because they don't move it as much.
I was going to say, do people come to see you for this problem because of pain, or is it because of stiffness and lack of function?
It's more for pain. More for pain, because you can really accommodate quite a bit of stiffness in this joint. And actually,
you can still get to your pinky with...
not always, but that's one of the treatments is to do a fusion there, which I think I've done once.
Really?
Once
in 13 years?
Yep.
Really?
Yeah, it's just not very common. Yeah.
And it's not so common because some newer procedures that we're going to get into.
Yeah, but also you do need mobility, some mobility of the thumb. It is somewhat debilitating because you can't get your hand flat. The position of fusion's a little awkward.
Oh, okay.
Yeah.
Because you have to fuse it in that plane a little bit so
Correct.
You can use it as a post.
So you can use it as a post, yep.
Okay. Understood. So patient comes into your office and they've had pain and, increasing for a year or two. X-rays show some arthritis at that thumb CMC joint.
Sure.
What do you walk me through the conversation?
Sure. I always talk to them about what's the least invasive to the most invasive. You can start off with, if they can tolerate it, medications that kind of decrease the inflammation or that treat the pain.
And those would be?
Like a non-steroidal anti-inflammatory, ibuprofen.
Does that work pretty well?
They do work. They don't target the joint. Your whole body sees that medication, right. So it's not as effective sometimes. There are some topical anti-inflammatories, like diclofenac is a nice medication.
You find people like that?
I do find people like that. Even lidoderm patches, some people have it.
Is that still pretty expensive?
It is pretty expensive.
Okay.
That's probably the biggest issue there.
That was a roadblock.
Sure.
Ordering that for other joints. But.
You get authorization requests and that kind of thing. Then you can move up the ladder of maybe a brace, something like a splint that'll help stabilize the thumb. Downside to that is if you do anything that involves water or getting your hand in dirt, like most of our patients have some sort of a hobby it's difficult to use that. Some people find a splint at nighttime is really helpful. They wear that to bed. And then moving up along that, steroid injections are probably the biggest thing we do that's non-operative.
And fairly effective for a naive person to steroids?
For the first injection, that can help their symptoms 6 months to even up to a year.
So you have some people come back a year later and say, hey, it worked great, let's do it again.
Yeah.
Is that the injection where you got to pull on the thumb
a little bit? Yeah.
It's just, I hate the idea of needles myself. Just the thought of that injection. You pull on the thumb, create a little space.
They do pretty well. They do pretty well. And
probably
as you get better,
as
time goes on, you get really good.
Me as a resident at the VA as a second year, and you know what the problem is, and you're like, how do we get in that joint?
Exactly.
Is there space? I mean, if it's bone on bone, sometimes you think like, how do you even get a needle into the joint? Does the capsule expand?
But really, the capsule expands, and if you think about it, you're trying to calm down the inflammation of the capsule. So if you get it into the capsule, you're probably doing just as good.
Okay.
Yeah.
And so is that a pretty common thing before surgery? You'll try a cortisone shot?
I do them all the time.
What if the cortisone shot doesn't work for more than a day or two? Can someone have surgery within a few weeks, or do you make people wait because of the steroid injection?
I do. There's been some recent data, some recent studies that show it increases the risk of infection if you go in within 3 months of a shot.
Okay.
And that was done. That was actually done for trigger finger surgery. A little different problem.
And that's less complex too.
Yeah, and even there's been some studies recently on carpal tunnel as well with proximity of shots to the time of surgery. I just tell them 3 months is probably the safe period of waiting.
So the person who wants to have surgery, so the surgery you propose to them, walk me through this, because I found this fascinating in residency, what kind of how you treat that joint,
Sure.
right? It's not that normally you think about it.
It's an arthroplasty, right?
It is,
right.
But it's just a different way of thinking about it.
Sure.
In some respects.
Sure.
So
I try to
address
explain it. You know, we don't put metal and plastic in the thumb
Right.
like they do in the hips and knees and these other implants. It's actually
And why do you think that is?
Part of it's
wear out quicker?
yeah, and part of it is the forces across the bone. The bone just isn't as strong as it is in the knee. You know, you're walking on your knees
Right.
on your legs all day long, so that bone's much stronger, and so the relative difference between the metal that you would put in and the bone is so much stiffer in the knee. So you do that in the thumb, it's going to wear out potentially.
Okay.
Plus, it's a joint that has a lot of mobility, so potential is higher for like dislocations, that kind of thing.
That'd be just a disaster. I can
It would
only
be,
imagine.
yeah. And there have been a number of implants that have been tried for it. I've never done one because they've just the tried and true procedure is to actually take a bone out called the trapezium, and it's a bone that actually has a couple articulations, or it meets up with other bones in the wrist, and patients also can get arthritis there. So by taking that bone out, you're taking out that source of pain. Typically when we take the bone out, there's no cartilage left.
Right.
It's just bone on bone.
Right.
Then we use a tendon, which sounds a little crazy, but we can use a tendon from the forearm to reconstruct the ligaments, and then the rest of that.
Do you use the FCR?
I use FCR. Mm-hmm.
Okay.
If we don't have FCR, I use 100% of FCR.
Yep.
If we don't have FCR available, the palmaris can be used as an interposition.
And the FCR, for people listening, is on the palm side. It's that big tendon you can feel kind of running down the thumb side of your forearm.
Correct. Yeah. Mm-hmm.
And so you just split that in half?
You can take half of it, or you can take all of it.
Okay. Mm-hmm. Do you leave it attached, or do you take?
I take it off completely off the muscle. Mm-hmm.
And then what do you do with it?
And then so one of the principles of the reconstruction I do is to try to give back stability of that joint.
Yeah.
Because you're taking a important bone out of the chain that you're trying to use as a post to pinch. So you need some stability, and so we drill a hole in the metacarpal, which is the bone next to the trapezium.
Okay.
And then that piece of tendon goes up through that hole.
So that keeps it there.
It keeps it there, and then we bring it back around itself, and then actually ball it up into a ball you've heard it called an anchovy, I'm sure. Right. I don't know where that comes from. Right.
You're
an
just
anchovy.
Like, anchovy.
The anchovy procedure. Right. But you basically create a ball of tendon that then creates a scaffold for the scar tissue to form to.
That gets rid of their pain because the arthritic bone's gone.
Correct.
But what you mentioned earlier about potentially dislocating, the thing I never quite understood is, does the thumb still maybe kind of subluxate, or is it held in place perfectly when you do that, or can it kind of...
It can subside.
Okay.
The metacarpal, sometimes on an x-ray afterwards, will be a little bit subsided.
Doesn't tend to matter, though?
But doesn't matter. Mm-mm. Nope, they've looked at that in studies, and it really is not an issue. The key is getting the trapezium out.
Okay. So if you leave, if somehow you leave 25% of the trapezium in there,
and they're
still going to have
They
problems.
used to take out half of the trapezium.
Okay.
That was an earlier description of this.
But they came to realize that taking out the whole thing was better.
It does work really well, because then you don't have to worry about arthritis that next joint up.
Is this a surgery someone has to be hospitalized for?
Oh no, they're done outpatient.
On the same day?
Yep, they come in. Typically either an anesthetic where their arm's put to sleep, or they go to sleep for the surgery.
How long does it take typically?
For just the arthroplasty, about an hour.
Okay.
A little more.
That seems pretty quick.
Yeah.
And they wake up, if they've had a block, they have no pain.
Yep. They go home. And
how long is it sore then after that for them?
I always warn them. That's probably the biggest thing that they need to be clear about before surgery, is that it takes a good 6 months for all the soreness to go away.
Really?
Because you've replaced the arthritic pain now with the pain from surgery, or the soreness.
When do they notice that? Okay, the arthritic pain's at least gone, and this is different.
Usually a couple weeks. They
pretty
can tell.
Quickly.
Mm-hmm.
So are you putting them in a splint then for a couple weeks?
Yeah. So typically they go into a removable splint that they can take off to shower. It's a little more convenient. If they want, they can go into a cast.
Yep.
But
and then how long will you split them?
6 weeks, typically.
6 weeks.
Mm-hmm.
Okay. So it sounds like the recoveries, other than the soreness, at 6 weeks, do they get to start using their thumb again?
Oh, yeah. They go into...
They can grab stuff.
Mm-hmm. They can pinch.
And you're not you're not crossing your fingers when you go home at
night? No.
Because, failures are...
They can't... There are potential for failures, and there are some revision procedures that can be done. One thing is always we have to look at the next joint up, the metacarpal. Because the metacarpal phalangeal joint, which is the next joint out towards the tip, if that joint collapses, that one, typically we fuse that joint or do some sort of procedure to limit how much it extends.
Yeah.
Which is probably 25% of the patients have something done there.
Is it a reasonable expectation after the surgery that they have fairly normal function, or do they always feel a little decreased strength?
That's probably the other thing, the other take-home message when I'm talking to them before surgery is the pain's gone, and it takes 6 months to go away, but they're never as strong as they once were, because we've taken out a bone and it's going to be a little weaker.
And what do you do with that tendon you're taking half of, the FCR? Is there any downside effect of taking that?
No, you can take the whole thing. It's not a problem.
Don't even need it?
Yep.
Really? So it's kind of like the palmaris in some respects, but it's just a bigger tendon.
Bigger tendon. You have your FC, as long as your FC works. I occasionally will take half of FCR. You can actually take APL. Some surgeons put other synthetic materials in that space.
Yeah. So would you say this is a pretty common surgery in your practice?
Very common, yep.
And this is something that you kind of have grown towards and tried to...
Yeah, it's funny. You don't do a lot of them your first year because you're giving everybody steroid shots, and you really don't start working on these until probably 2 or 3 years in. And
has your technique changed from year 0 to year 13, other than getting more efficient, and or is it pretty much a surgery that's been figured out?
It's pretty much a surgery that's been figured out. They've been doing it since the 1950s.
Yeah.
That's when it was first described. So
you're not looking into getting some intellectual property on metal and plastic at that joint?
No, not even a little bit. No, this works great.
Okay.
Yep.
Well, we very much appreciate you coming on. This
thanks.
is fantastic information, especially for a dumb sports guy like me, trying to rebuff my hand knowledge a little bit. And thank you very much, Trish. It's been great.
Great. Thank you.
Yeah. Thanks for listening to Joint Effort, a podcast from Des Moines Orthopaedic Surgeons. If you have questions about this podcast and wish to schedule an appointment with a surgeon, call 515-224-1414 or visit DMOS.com.